Once again, good evening and a very warm welcome to our webinar on heartburn and acid reflux testing and treatment. My name is Louise and I'm hosting this session. I'm delighted to be joined by our expert speaker, Mr. Ahmed Hamouda, consultant upper GI surgeon. Tonight's session will begin with a presentation from Mr. Hamouda, followed by a live Q&A session. If you have any questions, please feel free to submit them using the Q&A icon at the bottom of your screen. You're welcome to ask anonymously or include your name. Just a quick note that this session is being recorded, so any names shared may be visible in the recording. To help us get through as many questions as possible, please do keep them brief. If you're interested in booking a consultation, we'll share all the relevant contact details at the end of the session. Now over to you, Mr. Hamouda.
Thank you very much, Louise. Thank you to all those attending. Today, I'd like to talk to you about heartburn and more specifically about reflux testing and how we go on to treating this condition. So a little bit about myself. I graduated in 1992 from Cairo, and I completed my training here in London. I then did 2 fellowships, one to do with the bile ducts and gallstones, and another to do with weight loss surgery. I hold a professorship of general surgery at the university. So we're going to try and cover as much as possible regarding heartburn and reflux, and these are the topics we're going to be talking about in succession. I'll try and be as brief as possible so that you get a chance at the end of it to ask as many questions as you can, and hopefully I'll be finishing in about 30 minutes. So a bit of history about reflux disease. The symptoms were first described back in 1925 when a link was made between heartburn symptoms and the relationship to hiatus hernias, which is a structural anatomical deficiency where the stomach is being pushed up above the diaphragm into the chest. Further on, in 1934, a gastroenterologist found that reflux was mostly attributed to the presence of acid in the stomach, and that was flushing up into the gullet. So GORD or GERD, depending on whether you start the esophagus with an O or an E, is a chronic condition, and it's a condition where the acid that's normally in the stomach will find its way through the leaky valve at the lower end of the gullet and push up into the gullet, causing these symptoms of discomfort. Now, it's really important to mention that the valve normally is present at the lower end of the gullet here as a result of the folds of mucosa, the lining, the thickness of the stomach here, the acute angle, what we call the angle of His, and some of the ligaments that surround this area. That is what structurally gives the valve its strength. So it's a common condition, reflux and heartburn. At least 10-20% of people have suffered with some type of reflux at some point in their life. Some of the symptoms can occur almost on a daily basis. The 2 main symptoms that we talk about is this feeling of burning behind the chest plate, especially after a meal or after some food types that can give you this type of presentation. And the other real important symptom is regurgitation, where there's a sensation that fluid is flushing up into the gullet and into the back of the mouth, sometimes when you're lying flat, and you get this sort of effect where you just feel that there's too much fluid coming up, and it's called regurgitation. We know that gastroesophageal reflux disease is linked to certain lifestyle patterns and habits, smoking being one of them, stress, for example. Being overweight certainly doesn't help, as it increases the abdominal pressure, therefore pushing stomach contents up into the gullet. Pregnancy is a natural, obviously, event where people get reflux with it. Eating a large meal very late at night where you just go and lie flat in bed and therefore gravity will push everything back up into the gullet again, or certain beverages such as alcohol or coffee. There are certain medications that can also cause it to worsen, and specifically non-steroidal anti-inflammatory drugs. So things like aspirin, diclofenac, ibuprofen, those drugs can increase the stomach acid and cause problems. So the symptoms that are very typical are the 2 that we mentioned, heartburn and regurgitation. Less typically, you will have a feeling of food sticking behind the chest plate. Chest pain, very similar to pain that people get with perhaps maybe, a lung infection, or if you've had sort of a minor heart attack. Water brash, globus sensations means that you feel that there's something at the very top of your throat which is stuck. Nausea, and interestingly enough, reflux and heartburn can cause erosion to the back of the teeth, so dental issues. And if the fluid spills over into the lung, then you get a lot of coughing, spluttering at nighttime, particularly with wheezing and hoarseness of voice. Diagnosis is quite simple because usually when you present with these symptoms in a clinic, it's quite obvious to the doctor, the specialist who's there, that you suffer with gastroesophageal reflux. And the response to antacids, because you probably will have been given antacids by your doctor to treat these, by your GP to treat these symptoms. So a response to proton pump inhibitors such as omeprazole, lansoprazole, esomeprazole is really important, because if those medications aren't actually giving you a relief from your symptoms, then there might be other reasons why you're getting your symptoms, not necessarily reflux. Further evaluation is required if there's alarm features or risk factors for Barrett's. Now, Barrett's is a condition where the lower end of the gullet, as a result of the acid that's coming up into it on a regular basis, is protecting itself by adopting the lining of the stomach. So the lining of the stomach creeps up onto the lower end of the gullet, and that is called Barrett's. Why is it important? Because in a very small percentage of people who have Barrett's, they can then go on to develop something a bit more serious. So if you've been diagnosed with Barrett's, you probably will be on something called a surveillance program, where you've been asked to come into the hospital every 2 to 3 years to have a check endoscopy and some biopsies, and check to make sure that the Barrett's cells are not changing into something a bit more serious. And of course, these are the alarm features for diseases that are a bit more sinister. So on your left-hand side, gastrointestinal malignancy. If you have new onset of indigestion after 60 years, or there's evidence that there's been bleeding leading to anemia, unexplained weight loss, or tightness in just behind the chest plate where food is sticking on a regular basis, or if it's painful to swallow with persistent vomiting, and of course, if there's a family history of similar sort of issues, then those are alarm features, alarm symptoms that we look at to investigate a bit further. On the right-hand side, you've got the alarm features of Barrett's, which I just described earlier, and that's the duration of reflux from 5 to 10 years, age 50 or older, and male with hiatus hernias, obesity, or smoking, and if the reflux is happening at nighttime. So how do we evaluate? Well, if you have reflux and you've been on medication for a few years, but you're finding that your reflux is still quite significant and you need increasing doses of medication, or in addition to your tablets, you need to take some Gaviscon and Reni on a regular basis, or you're worried about the side effects, then you should really come and see a specialist like myself, where I do a series of tests. The most important is an upper GI endoscopy or a camera test. And basically this will show whether you have a hiatus hernia, whether there is esophagitis, which is inflammation of the lower end of the gullet, and whether that's led to erosions or an ulcer. And of course, if there's Barrett's in addition, then biopsies from the Barrett's are really important. As I mentioned earlier, if you've been diagnosed with Barrett's, you probably need to have a surveillance endoscopy every 2 to 3 years with further biopsies. So if that's the case, then endoscopy is the first line of investigation. The second line of investigation that I think is really important, because a lot of people who come and see me in clinic, they say, well, we've got these symptoms, and the symptoms are very suggestive, or they could be atypical symptoms that I mentioned in my previous slide. And the only way really to clinch the diagnosis, apart from doing endoscopy, is to do something called a pH test, an ambulatory pH monitoring. And that is done with a Bravo capsule. And basically what it is it's a little probe that sits in the gullet 2 inches above where the stomach is, and it measures how much acid comes up into the gullet over a period of time. This can be combined with something called an esophageal manometry, which basically measures the pressure exerted by the gullet as it squeezes food down into the stomach. And it's a technical procedure which gives us a bit more information. Additionally, barium and CT. A barium is where you are asked to drink some dye down, and an X-ray is done to look at the shape of the lower end of the gullet and perhaps tip your head down with the barium to see if it refluxes back up into the gullet. And a CT scan gives us a lot of information about all the structures surrounding the gullet and the stomach, which is really important because if you're planning an operation, if you're planning an intervention, you want to know if there's anything around it which is causing more of the problem or contributing to it, or could perhaps stop you from doing the operation. So a bit more to, we want to talk a bit more about the Bravo reflux testing system, which is something that we've introduced here at Benedin for the last 2 years. And it's a really innovative technique, which is essential for people who are suffering with reflux, but also want to have management in the form of an intervention, an operation or procedure. It's a quick procedure. It's done very same as a camera. So initially, I give you sedation and throat spray, pop down with the camera, check everything's fine, and then do some measurements and pop down with the probe, which you can see here, that little piece of plastic and metal, and then attach it to the side wall of the gullet 2 inches above the junction with the stomach. It's then released, this whole mechanism is released, and the probe is left in place for up to 4 days. Over that period of time, you have a recorder which is worn on the waist or the chest, and the probe will send wireless signals to the recorder regarding how much acid is coming up and what times during the day it is doing so. So this is just a diagrammatic representation of the system. This is the probe being inserted into the gullet. It's suctioned onto the lining of the gullet, and a pin goes through the lining of the gullet to hold it in place. It's transmitting wireless signals here, and after approximately 4 days, the pin and the bit of lining will then slough off and fall away, and it then goes through the back passage. So you don't need to have it removed. Essentially, what then happens is the recorder gets sent back to us again in the hospital, and I get this trace, which you can see in front of you here. And this line here is the line where the acid in the gullet, if it drops below that line, there's too much acid in the gullet. So essentially, everything above the line, all these traces above the line, are more or less in keeping with normal. When it drops down to below the line and sustains it, and this is a 4-day recording, by the way, so you will find that there are significant episodes of reflux here during the 4 days. Quite significant episodes of reflux lasting for a period of time. We use very specific software to analyze all this, and it gives us a score, it gives me a score. I can then sit down in clinic with you, go through the test and say, well, actually, you have a problem, and this problem can only be resolved by doing one of 2 things. And I'll obviously come to that in a second. This is just the endoscope showing you a picture of a Heyt's hernia internally. So this is the scope passing through the lower end of the gullet here and into the stomach. It's then, if you imagine it continuing up here and just popping back and looking onto itself, it's looking at this pit. And this pit is where the stomach has been pushed up above the diaphragm. So this is the size of the Heyt's hernia. You can see another one here, which is slightly larger, and that's the size of the Heyt's hernia. Normally, you would not see this pit. You would just see the stomach lining coming up to the scope here, and there wouldn't be a pit surrounding the scope. Now, this is a bit technical, but we separate Heyt's hernias into types. If you look at this white marker here, this is where the junction is between the stomach and the gullet. If the white marker is pushed up above the diaphragm, we call it a sliding hiatus hernia. If the white marker stays where it's supposed to be, but a bit of stomach pushes up next to it, it's called a rolling hiatus hernia. And if both things happen where the white marker is pushed up, but also you get a patch of stomach above the diaphragm, it's a mixed hiatus hernia. The only reason I discuss this with you is because if you have a rolling hiatus hernia, which is very rare, the most common hiatus hernia is sliding, but if you do have a rolling hiatus hernia, it's an indication to have surgery straight away because unfortunately this patch of stomach is known to cause problems such as twist or obstruction or possibly even strangulation where the blood supply is cut off to that bit of stomach. So, GORD, reflux, acid coming up into the gullet. Can this cause problems? Yes, it can. The first issue I alluded to previously was esophagitis, which is inflammation. It can cause inflammation of the lower end of the gullet and the lining. As a result of too much inflammation, you can get a persistent narrowing, and that's called a stricture, as a result of the inflammation being there for many, many years. We can get Barrett's, which I described previously. It's creeping up of the stomach lining onto the lower end of the gullet. In a very small percentage of people who have Barrett's, it can go on to a form of cancer. And of course, it can cause, if the acid is coming up into the back end of the gullet and spilling over into the lungs or the larynx, it can cause injury to the larynx or a pneumonia infection of the chest as a result of aspiration. The 4 grades of esophagitis, inflammation, grade A to D. The first grade you can see here, there's 1 or 2 streaks that are quite shallow in length. And then grade B is when you get 3 or more streaks and they're increasing in length. With grade C, you get an area, a circumference. So a quarter of the circumference is now inflamed. It's not just a single streak. And in grade D, the whole of the circumference has become inflamed and it's moving on to become a stricture. These are the 3 complications of reflux. And this is what we see when we go in with a camera. So I go in with the camera and I can see this sort of what I would call a slightly reddish appearance of the normal lining of the gullet. And here I can see that there's a different color. We use narrowband light to look at this in greater detail. But this segment is Barrett's, and what's happened is the lining of the stomach lower down here has started creeping up onto the gullet to protect it. This is a growth, and this is when it's created a cancer. This here is a stricture, so it's benign, but what's happened is as a result of the inflammation, you may remember the last slide where we had grade D, esophagitis. It was all very inflamed, and if the whole circumference is involved, then it leads to a stricture. What can we do with reflux? How can we treat it? Well, the first thing that everybody will speak to you about when you have reflux is lifestyle and dietary change. You need to identify the foodstuffs, the drinks that cause you reflux and stop using them, stop taking them, stop eating them if you can. Sometimes very difficult to do because there'll be people who have reflux with almost anything that they eat. The second thing is lifestyle measures. So you've got to stop smoking, you've got to lose weight. If you're sleeping at night, you should really raise the pillow and definitely have dinner very early in the evening. So have your dinners at 5 and go to bed at maybe 9 or 10 to try and prevent or try and get all the food that's in your stomach to have moved on into the bowel so that it doesn't cause much of a problem anymore. And then the next stage is once you've tried the lifestyle and dietary change, hasn't really worked, you will go on to medication. And of course, the medication that's very common is coating medication. So things that you take to line the side walls of the gullet, things like Gaviscon and Reni. But if that doesn't work, then you go on to a group of medicines called antacids. And those are H2 receptor blockers or proton pump inhibitors. H2 receptor blockers are an older category of medication, which we used to use previous to the proton pump inhibitors. An example is famotidine, for example. The proton pump inhibitors are the gold standard. You'll get things like omeprazole, lansoprazole, esomeprazole, pantoprazole. Those are the ones where basically, essentially, they control the acid in the stomach and decrease the amount of acid production by up to 95%. It's called acid suppression. Yeah? Now, acid suppression is great, and it's been in use for years. We've used the medication for years. More recently now, we're becoming aware of the side effects of acid suppression. And you may have heard in the news, you may have read the articles where the use of PPIs has been linked to dementia, for example. It was in the news about a week ago, and the research had suggested that there was almost a 30% chance of developing, some form of dementia. This is all caused by the fact that acid in the stomach is essential. It is really quite useful for 2 things. It breaks down food substances that we are required to absorb and use in our body. And second, it protects against infections, especially infections of the gut. So as a result of suppressing the acid in the stomach, you can get these infections in the gut and these deficiencies of essential nutrients that are required in the body because the acid isn't there to break them down anymore to allow the body to absorb them. As a result of deficiency of iron, magnesium, calcium, and B12, you then get the side effects that are, for example, a minor heart attack or a stroke, things like dementia. We talk about chronic kidney disease, and people who have CKD should really not be on proton pump inhibitors. Osteoporosis. So we now realize that proton pump inhibitors and antacids generally are not a good thing in the long term. And then, of course, you can try, this probably should have preceded, this slide should have come before the slide on the medication, but you need to try dietary changes. So try and avoid things that are going to cause you and trigger your symptoms, like fried food, chili powder, pepper, fatty meats, for example. And of course, citrus fruits. Some people react to chocolate, peppermint, and fizzy drink. And whatever you react to, you should really keep a diary of and try and avoid in the future. And then you've got the good foods where people say to you, well, actually, have a banana if you've got some reflux, or try oatmeal, brown rice, carrots, for example, or watermelon, lettuce. And then milk is been known to try and, again, decrease the amount of reflux, coat the lower end of the gullet. So all these things are lifestyle changes and dietary changes that you can try before you have the medication. And then we move on. So we've had three things now, three categories, which is one, lifestyle and dietary change, two, medication to treat your reflux, and we talked about side effects, obviously. Now, if you are refractory, so in other words, your symptoms are not being treated by the medication, if you need increasing doses of the medication, if it's difficult for you to take the medication because you forget, for example, or if you've decided that the medication is not a good thing for you because you're worried about the side effects, then your third option is consider surgery. And surgery to treat this condition has been described very early on when it was first performed in 1955 by Rudolf Nissen. Essentially, he theorized that if the stomach were to be wrapped around the lower end of the gullet, it would recreate this valve mechanism that has been lost over the years that I described to you earlier, and that was causing the reflux to occur. So basically, he described this operation where with keyhole surgery, what we do now is I go in, and if there's a Height's hernia, I free it up, I dissect it, make sure that it's free from all the attachments, and then bring it down back into the abdominal cavity where it belongs. I then put stitches into the diaphragm to make it snug around the gullet. And the last bit here would be to take the floppy bit of the stomach, go behind the gullet, and then back onto itself and stitch it with non-absorbable sutures, which do not dissolve. So sutures that stay there for life, and the whole purpose is to create this wrap around the lower end of the gullet. So, as described, it's two-part. No, actually, it's three parts because we've done the Height's hernia, so we've brought that down. The second part is to put sutures into the esophageal hiatus in the diaphragm to stitch it and make it snug around the gullet. And the third part is to take the floppy bit, we call it the gastric fundus, behind the gullet and wrap it back onto itself, put stitches in that do not absorb. So what does this actually do? Well, if you look at the X-ray here, and if you look at a diagram that has been superimposed on the X-ray, where the wrap is, every time you have something to eat, for example, your stomach contracts because it's trying to push food down. What it does is also the wrap contracts around the lower end of the gullet because the whole of the stomach is trying to squeeze. So that bit that we use to do a wrap is also squeezing the lower end of the gullet, therefore increasing the pressure in that area, and therefore preventing the acid that sits below the wrap from going up into the gullet above the wrap. It is quite an effective procedure, and we know that at 10 years, almost 90% of patients who have had a wrap were still free of significant reflux. Now, if you've had this operation and you get some mild reflux symptoms, then that is a much better option than having the reflux for such a long, having significant reflux for such a long period of time, which will cause damage to the lower end of your gullet. So if you've had this operation 2 or 3 years down the line, if you get an episode of reflux once a month and you treat that with Gaviscon, then that in itself is a marked improvement. So even though, it isn't 100%, even if it's a very mild reflux that you get on occasion, then that's a better option than having the significant amount of reflux from before. Every operation has its risks. So if you are actually creating a high pressure zone at the lower end of the gullet, you're preventing the acid from going up, but at the same time, you are probably going to make it more difficult for chunks of food to go down through. So this word dysphagia means food sticking above the wrap. And what's normal after this operation is that you would have 1 week of liquids followed by 1 week of soft, sloppy food. And then you go on to solids, but you eat little and often and you chew your food very well. And this effect you need to get used to so that in 3 or 6 months, you're now used to that wrap. You're eating little and often you're chewing your food well and you don't get any stuck episodes. It also means that you burp less, you're more windy down the bottom end, and you're a bit more bloated in the stomach area. In the long term, the wrap can move back up into the chest again, especially if you're heavy lifting, going to the gym, doing squats with weights, lifting heavy slabs, pieces of furniture. You might end up with a wrap migration, so please be careful, which can lead to a recurrence of these symptoms. And if the vagal nerve, which sits very close to where the gullet is bruised, then you can have altered bowel habits, mostly in the form of loose stools. There are other treatments apart from the fundoplication that I described, but they are treatments that still need quite a bit of research involved. They need to have long-term results so that people can look at them and then compare them to the fundoplication. And one of them is a mechanism where radio frequency is used to thicken the lower end of the esophageal muscle. The other is a mechanism, a device like this one, which is used to stitch the side wall of the stomach onto the gullet and therefore recreate what we call the angle of His. You may recall from earlier in the presentation. So create a bit of an angle there that can almost act like a valve. So in summary, GERD, reflux is a common GI complaint. It can lead to long-standing issues such as inflammation, strictures, or Barrett's esophagus, which in a very small percentage can change to something else. Essentially, if you have this condition, you can treat it with lifestyle and dietary modification, or you can go on to medications, but please be careful because there is a cost to the medication. There's also, more importantly, side effects for the long-term use of medication, which we discussed, and you may not be compliant. You may not want to take a tablet every single day of your life, maybe once or twice a day. Surgery at the end of the day can be effective for controlling the symptoms. In 90% of the cases, it lasts for a very long period of time, more than 10 years, and it can improve your quality of life. Once you've had the surgery, you stop taking the tablets the day after your surgery. Thank you very much for listening to my presentation, and I'm going to go back to Louise.
Thank you. Let's move on to our Q&A session now. We're really pleased to have so many of you with us today. Whilst we might not be able to get through every question, we'll do our best as we can. On this slide, you can find information on arranging treatment. First question, is there any proven connection between acid reflux and heart conditions, such as gastrocardiac syndrome?
Well, if you go back to the slides that I was talking about earlier, the symptoms are very similar. So chest pain, and that's why you need to differentiate between chest pain caused by reflux or chest pain caused by cardiac issues. And normally that's something that your GP, or if you go into hospital, they will be very good with, because they'll run some cardiac tests, they'll check the heart and make sure that everything's all right, and then it will be more or less likely that it's reflux, in which case you'd be sent to someone like myself, where I do an endoscopy and confirm the diagnosis. Also, in terms of the side effects of the medications, you may recall on that slide, I said that there was a chance and an increased risk of heart conditions or myocardial infarction as a result of long-term use of medications.
Thank you. And what options and tests are there available for the use of lansoprazole for 3 months that allows, for 3 months that allows diarrhea to develop? So how do you test?
So my understanding is that somebody's been using lansoprazole and they've developed diarrhea, and they want to know what tests are available. Well, the first thing would be, first of all, to go back to your GP and to come off the lansoprazole and see if that actually helps. Because if it's the lansoprazole, as soon as you stop it, then we will know that it's your symptoms will improve and you no longer have an issue. If you've stopped the lansoprazole and you still have symptoms, then your GP will most likely refer you for a colonoscopy and some tests on your bowel to check and take some biopsies. But that's what it would be. It would need some investigation, yes.
Thanks. Samuel says they've had a sliding hiatus hernia for which they've been taking pantoprazole. They've been taking this for about 4 months. When they're lying in bed, they still get a reflux and they're continuously clearing their throat. They've had an endoscopy and a barium swallow. What is the best option to proceed to manage this?
Well, we need to know what the endoscopy and the barium swallow have shown. So I'm hopeful that we've got some information from it. Remember I said about the endoscopy, we need to know if you've got esophagitis, an ulcer, a hiatus hernia. If that's the case, then please come and see someone like myself to chat about options. It is likely that surgery might be on the cards for you, where you can have an operation to fix this and come off your medication.
Thank you. Are there any non-surgical interventions, such as exercises, that have been proven to work in improving their LES?
I'm aware of people who've used certain what you call gadgets to strengthen the lower end of the esophagus, things that you put in your mouth, create a vacuum, for example. I'm aware of them, but I don't know that they have any long-term effects that are sustainable. So apart from what I've mentioned today, which is lifestyle, dietary modification, medications, and surgery, I don't know that anything else works as well.
Can breathlessness be a symptom of GORD on its own, or would you need to see other symptoms as well?
So breathlessness can be a symptom of a large hiatus hernia. If you've got a large hiatus hernia, and remember I said about hiatus hernias, but I didn't actually explain that some of the hiatus hernias can be quite large, where a large portion of the stomach is up in the chest, compressing the lung. And you can have almost 1/2 to 3/4 of the stomach up in the chest if you've got a really massive hiatus hernia. So that in itself can be a cause for breathlessness. The other cause for breathlessness that I can think about is that if your reflux is causing aspiration, where it's spilling over into the lung, it's silent. So in other words, you don't get the chest pain with it, but you cough and splutter at night and you develop aspiration pneumonia. You can be breathless as a result of that, obviously, as well.
Thank you. Tony's asking, will a grade A hiatus hernia repair itself with a change of lifestyle, such as anti-reflux modifications?
Very good question. Hiatus hernias do not repair themselves. So very much like a hernia anywhere else in the body, it's a tear. Once you've got the tear, it's not going to fix and heal on its own, unfortunately. So it can remain stable, the same size for a long period of time, or it can increase in size over a period of time, in which case it will become bigger. But there is no incidence where a hiatus hernia has repaired itself.
Thank you. Do you use the reflux stop operation? This person understands it's a silicone device implanted near the stomach wall.
Yes. So a reflux stop is an operation that's, again, new to the market. And I try to allude to this in my presentation. You're comparing everything against the fundoplication, which is the gold standard. You've got a Lynx procedure, which is a magnetic ring around the lower end of the gullet. You've got the Stretta, which I said was the radiofrequency ablation. And then you've got the transoral incisionless fundoplication. More recently, the reflux stop, which is basically a silicone ball that's inserted under keyhole surgery into the lower end of, not into, but just across the lower end of the gullet, with a bit of the stomach stitched on top of it to create this angle of His, to give you an angle at the lower end of the gullet. So again, very similar to the transoral incision with fundoplication. We don't do it at the Benetton, and it is still one of those things that needs at least 10 years of results for us to be able to recommend it on a regular basis.
Thank you. When Paul moves his upper body, his chest has a muscular ache, which he assumes is the inflamed esophagus. Is that normal?
Again, very difficult to tell without doing some tests and investigations. So you probably need to come in and have an endoscopy to check. If your gullet is absolutely fine on the endoscopy and there's no evidence of esophagitis, then it probably isn't anything to do with reflux, and it could be something else.
How long is it considered to be acceptable, safe to take omeprazole?
Very good question. Again, we don't know. We know that long-term use, and again, it's a very vague term. When I say long-term, is it 2 years? Is it 5 or 10? Don't know, to be honest with you. People who have any of the conditions I described in my previous slide with the side effects should probably stay clear of it if possible. And if you have taken it for a long period of time and there's been no issues with it, then perhaps maybe continue. I would have a chat with your GP.
This person has Barrett's and they take PPI, which doesn't seem to be working. What should they do?
Well, you've got Barrett's. How do you know that PPI is not working? The only way to tell would be another repeat endoscopy where the length of the Barrett segment is increasing, or biopsies reveal that there's been some change in the Barrett segment. Essentially, you're doing the right thing, because with Barrett's, you want to prevent any more acid from causing an increase in your Barrett's segment or severity. So you either need to continue taking medication or consider an intervention, such as an operation.
This lady was born bringing up her mother's milk. By the age of 13, after endoscopies, it was put down as a sliding hiatus hernia. They still do bring up food, but cope with it. Can they tick over like this?
Well, you mentioned that you were diagnosed with a sliding hiatus hernia. Do we know what was done with it? Is it just been left? And of course, if it has been left, we need to know what's happened to it. Is it increased in size? And if it has, then perhaps maybe it would be a good idea to have a conversation about how to treat it. If it has been dealt with, then it seems to be that you should now be bettering yourself. But if you aren't, then again, you might just need some investigations and tests to figure out what's going on.
Would weight loss medication, i.e. injections, be advisable when suffering with GERD?
Good question. Weight loss injections are very common, very popular these days. And what they do is two things. They decrease the craving and appetite by working on the satiety center in the brain. They also delay gastric emptying. So they are actually keeping food in the stomach for longer than it needs to be. As a result, I have seen patients who have had and developed reflux symptoms with them. And yes, I think it is possibly one of the side effects of having those medications. So you can either stop them, which I don't think you want to, but if not, then perhaps maybe come in and have some tests to try and figure out if there's anything else we can help you with.
Thank you. I can actually answer the next question. This person has a significant hiatus hernia with 1/3 of their stomach in their chest. They were told that Bendon could not do the operation as it's so significant, and they would need to go into ICU after the operation. And Bendon does not have that facility. Is that true? And that is indeed true. We do not have that facility, do we?
We don't, unfortunately. So Benetton, we've got no high dependency or intensive care units. And we are very happy to treat people, on a day surgery or one night stay basis. But when we think it's unsafe for us to do something and do an intervention, we always are very upfront and very honest about it.
Yeah, sorry about that. Are there specific exercises that can be undertaken to strengthen the stomach gullet muscles?
Exercise is generally a really very good thing, but when you've got a hiatus hernia and when there's been an incidence where the stomach has been pushed up into the chest above the diaphragm, then please avoid any exercises that increase your abdominal pressure. So I would give you an example of maybe squatting with weights. That in itself can cause an exacerbation of the problem. But if you're doing general aerobic fitness exercises, you should be absolutely fine and recommended.
Thank you. This person's just written about their mum. She's 74, suffered for nearly 8 years, had Gaviscon and omeprazole. She feels mucus draining from her head and is suffering so bad, up all night trying to eliminate it. Is she too old for the surgery, and what else can she try?
We are not ageist at all. We always look at people depending on their physical and physiological reserve. So you could have somebody who's 80 or 90 who's very fit and healthy because they've looked after themselves really well. And you could have somebody who's 40 who's suffering with quite a lot of medical problems, where we wouldn't be able to do the surgery safely at Benedict. So, I would recommend that you come in and have a chat and let's look at the whole situation.
Thank you. This one's rather acronym heavy. This person started on PPI due to SSRI. They still use the SSRI, but become so used to PPI, they can no longer go without the PPI. What protection can they use instead of PPI? I want to explain that for everyone else.
So they've been using a medication, which is SSRI, and basically that is a medication that required, the GP obviously gave them antacid medication to try and prevent any ulceration to the stomach, etc., or any side effects from the medication. But as I understand it, they've now stopped the SSRI, so there is no requirement for the PPI at all. And I wonder whether it would be a good idea to chat to your GP to wean you off the acid medication and see where you are. If there's no symptoms and you're weaning off gradually, then by all means, I think you should come off of it. I don't see any reason for you to continue to take it long term. If, however, you do develop symptoms, then you've always had reflux that was obviously masked by your PPI that you thought you were taking for something else. So I would suggest seeing the GP and weaning off your PPI.
What is 2 centimeter hiatus hernia? Sliding hiatus not mentioned, they say.
Yes. So very common. 2 centimeter sliding hiatus hernias are very common. The vast majority of hiatus hernias are sliding anyway. We said that previously. I don't think it's a rolling. Basically, if you think back to my slide, there was a white dot where the junction between the stomach and the esophagus was. That white dot has been pushed above the diaphragm by 2 centimeters, and we measure the length on endoscopy. So in essence, what you've got now is 2 centimeters of stomach above the diaphragm, and that's the length of the segment of the stomach.
Thank you. Is a chronic mucousy cough in the daytime, which they've had for 6 years, likely to be caused by reflux? This person's 60, they've had reflux since the age of 7. They've had tests, pH tests, etc., all normal, but the cough cannot be controlled without a steroid inhaler. Reflux improved after diet change, but constant cough is concerning. Respiratory specialist thinks it's about an overproduction of mucus, but tablets for this is not working.
Yes, I mean, you've covered it quite well in that you've actually said that you had the pH test which didn't show any reflux. And you may recall from my presentation, I said that that was the gold standard. If the pH test shows that there's no acid coming up into your gullet, then this isn't a reflux issue as such. Your respiratory physician has obviously looked at things and thought that the mucus was, overproduction of mucus was the reason why you were getting the chronic cough. I would suggest that this sounds more respiratory than it does reflux.
Thank you. This person has been taking omeprazole for a year now for gastritis that was diagnosed via a gastroscopy, which they had because of a non-specific anemia. They like to come off the PPI because of their history of anemia. And so how can they reduce the daily dose of 20 milligrams to every other day and see, can they do that and see how they get on? So every other day, 20 milligrams.
Absolutely. So I mentioned previously weaning off, and what you should do with PPIs is you should wean them off gradually. So if you're on 40, you need to go to 20 for maybe 2 or 3 days before you start taking it on alternate days. So do 20 alternate days for about maybe a week, and then try once every 3 days for another week, and then twice a week before you come off it the week after. So over a period of 4 weeks, you should wean off very gradually.
Okay. This person is on 2 lots of 20 per day, and they also have 2 lots of
Famotidine.
thank you. But they also have episodes of vomiting acid for days at a time. Is this the best option to manage the vomiting? And could it be something else?
Yes, it could be something else. I think you are on quite excessive doses of acid medication. And I would really want you to have an endoscopy and perhaps some further tests to try and figure out what's going on. Because either you're taking the medication that's not really helping in any way, in which case you shouldn't be taking such large doses, or there is such a big hysterenia and a big acid problem that the medication isn't touching it, in which case I think perhaps an operation would be required. So yes, I think that this is an indication for further testing.
Yeah, they do have a hiatus hernia. I guess it's just
Ah,
what size is it? Yeah, sorry, I missed that part.
okay.
This person has had a GI endoscopy and a CT barium scans on the NHS, and no problems were found. They're taking pantoprazole. I'm going to say that one, and the reflux seems to have settled, but now they're getting a feeling of something in their throat, which is uncomfortable, which I think is a symptom you mentioned. Do you know why this is?
Globus symptoms, we talked about it as being one of the atypical symptoms of reflux. And you've done really well in that you've had 2 good tests, CT and endoscopy. But I think what's missing is the pH test. So perhaps you need a Bravo pH test to figure out how much acid is coming up. And then we can be in a better situation, more informed, to see whether anything else could help, whether it's an increase in medication or whether it's consideration for surgery. That could possibly be the way forward.
Joan suffers from reflux and she takes lansoprazole. She also takes alendronic acid for
Yeah.
osteoporosis and has been told she'll have to stay on this lansoprazole because of it. She's worried about the long-term effects that it will cause her.
We talked about the long-term effects, of course. Alendronic acid is one of those things that needs protection, needs stomach protection. So I think that's why she's on the PPI. It's a difficult one. So it's a chat with the GP really to see whether they think that the long-term side effects of PPIs are so great that you need to come off it and then try something else, or maybe try a different medication, apart from alendronic acid. But there's no quick and easy answers for these situations sometimes. But as long as you're armed with the information, you can make a risk-benefit decision on what you should do. So whether it's stopping one medication or the other, it's really about risks and benefits. And I think that discussion should be with the GP.
Thank you. Glenn asks if natural supplements such as focal assist, focal assist, or even cure GERD. It's claimed on lots of websites and social media sites, apparently.
Yes, as I said to you previously, there's a lot out there, and a lot of people have got these devices that they suggest are helpful. My experience has been that people use them for a period of time, but their symptoms persist, or they come back in 2 or 3 years' time, and they need to have one of the gold standard treatments for this condition. So by all means, if you feel something is helping you, then use it with lifestyle and dietary modification medication. But don't persist. If after a year or 2 you still feel that there's an issue, then please come in and be tested and look at other options.
Lauren asks, what's the difference between your investigation to test pH and the NHS investigation option of having a monitor for 24 hours?
Yes, so when you have it done on the NHS, they do something called a wired pH test. So basically they put the probe down, but it's not wireless. It's attached to a very fine wire that sticks out through the nose. It then gets railroaded behind the ear and attaches itself to the recorder. They should still be able to test you for a period of anywhere between 3 and 4 days rather than just 24 hours. because the longer the test, the more information it gives. So you'll just be carrying the recorder as well as this tube that runs out of your nose for a period of anywhere between 3 and 4 days. The Bravo test is exactly the same, but it's wireless. So it sends wireless signals, and it doesn't need to be taken out at the end. It just drops out bottom end.
Is excessive mucus a symptom of silence reflux, and what could be done when Gaviscon and antacids have not worked?
The first part of the question is a simple yes. Second part of the question is what I was alluding to before. Come in and have tests. If the tests reveal that you do have an acid reflux problem, if it's quite significant, we can chat about surgery.
Okay. Would a raised electronic bed help stop reflux at night?
Very similar to using 2 or 3 pillows to prop up the back of the bed. If you've got an electronic bed, even better, that's absolutely fine. The whole issue is trying to use gravity at nighttime to prevent the acid from flushing up into the gullet. So as long as your head is higher than your waist area, then you're achieving that result.
Okay. Someone's asking about famotidine.
Famotidine, yes.
Famotidine. So I don't think we've covered off this one yet. Can you take it? How long can you take it for, and when?
So going back to my slide talking about medication, I mentioned antacids. I said that there was H2 receptor blockers and proton pump inhibitors. H2 receptor blockers are the original medication that was used many, many years ago to treat acid. Famotidine is one of those medications. It tends to reduce acid production by a significant amount, but not as much as proton pump inhibitors. So when proton pump inhibitors came onto the market, they were considered the gold standard medical management of reflux disease. And that's why the majority of people that I know, GPs, etc., prescribe PPIs. But certainly if famotidine is working for you and it's decreasing the acid in your stomach, it's giving you the symptom control that you need, then by all means, carry on taking it.
Just going to go to, we have several more questions, but I'm afraid we haven't got time for them all. The last one is, could you email us a copy of the slides? I think going through those slides again will help people. And yes, you will get a copy of the presentation. So if we haven't covered off your question, you have provided your name, we will follow up with an email. If you could just go on to the final slide, please. As a thank you for attending, we're pleased to offer 50% off the value of your consultation, a call back from your dedicated private patient advisor, an email with the recording of this session, treatment information and loyalty reward points, which will have the slides, updates on future events and health news. And we'd really appreciate it if you could take a moment to complete the short survey at the end of this session, as it helps us to improve and tailor future webinars to your needs. If you'd like to speak to someone to book a consultation, our private patient team is available until 8:30 this evening, and they're available 8 a.m. to 6 p.m. Monday to Friday. You'll find the contact number on your screen. We also have upcoming webinars on a range of topics, including hip and knee pain, tummy tuck surgery, diabetes and neurology, and many more. And you can sign up to these on our website. So finally, thank you from us all here at Benton Hospital for joining us today, and we hope to hear from you soon. So take care and goodbye.
Thank you.